Hey everyone, Dr. Emma Petcho here. I am here today to talk to you about exercise prescription as a physician. I am the founder of Empower You Health and Wellness, which is my own clinic. And in that clinic, I practice as an integrative naturopathic physician, practicing primary and adjunctive care, as well as I am a personal trainer certified through the American College of Sports Medicine. So I do personal training visits for patients as well as nutrition therapy. If you hear some sounds in the background, I'm here with my co-lecturer today, Ella. She's a 4-month-old rescue puppy with me from Texas, and she is going to town on her little chew toy. So if you hear any noise in the background, that's probably why. All right, so we'll get started. So my background in movement, why am I here lecturing to you today? I spent a decade as a gymnast and 2 years as a gymnastics coach. For the last decade, I've been a high school track and field coach for a high school out in Hood River. That's my relay team at state. I had 6 years myself of high school and college collegiate track and field experience where I was a pole vaulter. 4 years I spent working in recreation management at a college rec center at Portland State University. I have been a personal trainer through the American College of Sports Medicine, like I mentioned, for the past 4 years. I've been a naturopathic physician in Oregon, licensed for the past 3 years, and I completed 2 years of residency at NUNM. I guess it's 4 years now almost since I've been a naturopathic physician. And I spent 1 year redshirted as an athlete due to multiple overtraining injuries sustained in college. So I have experience in movement and in medicine, and I'm going to combine them together and talk about how we can safely prescribe movement to our patients. So what are some of our goals today? I'm going to close down my face here. So our main objectives include behavior change and exercise. What does that look like? Setting SMART goals, risk assessment, the actual prescribing of exercise, and FIT, which is exercise prescription guidelines. So let's get into it. First things first, I want to talk about behavior change and exercise, and we're going to go through the stages of change. So behavior change happens through 6 stages of change. There's pre-contemplation, contemplation, determination, action, maintenance, and relapse. So we're going to delve into these a little bit further. First things first, you have to identify that the stage the patient is in or your client is in. So the best way to do that is by naming the problem. This is identifying, it's clear, it's to the point, it's a personal statement, determining the readiness for the person to change. And to do this, you ask patients questions like, what do you know about this? How do you feel about this? What are you willing to do about this? And this theory or this process can be applied to any behavior that you're trying to change, whether it's movement, food, smoking cessation, etc. So as we're going through our interviews with patients, we're going to start to identify these stages based on these kind of keywords and triggers using that previous slide's name, determine, and ask. So for the pre-contemplation and contemplation stages, what do those look like? Our pre-contemplation stage, patients are unaware, unwilling, or uninterested in change. You might mention movement and exercise and why it's important, and they may be surprised or unwilling or just have no idea that it's an important factor in their life or their health. What the provider needs to do at that time is to obtain new information. So obtain information about the patient's health habits and health history and about the patient's knowledge about the topic and provide some information, but keep it light because recognize your patient completely doesn't have a clue that this is an important piece that they need to change in their lives. Your information is providing them with that new information and creating a decision conflict. So if the person has no idea that they need to move or need to exercise, provide them with a study or with some data saying people who exercise have a decreased risk of cardiovascular disease or improvement in their blood pressure or cholesterol levels, and create that decision conflict for them where they have the knowledge now and they know it would be a good thing for them. So then they have to think about, well, is this something I want to do? From there, we're going to move into the contemplation stage. Contemplation stage is where the patient knows about it, They're kind of ambivalent or conflicted about making the change. They might be thinking about making a change, but aren't quite sure if they want to commit. They might be defensive, saying like, this is something that I don't want to do, or they might even get a little angry or aggressive. Typically, you either see intense feelings in this stage or indecisive feelings in this stage. What the provider needs to do during this stage is to try to help them resolve their decision conflict by clarifying first and amplifying the conflict. So it sounds almost like the opposite thing. You're helping them resolve their decision conflict. They may know that they need to move, but they don't want to because they don't think they have time. So you need to then clarify why movement's important and make it so that the conflict's more amplified, meaning that they see a greater dissonance in their resistance to this change behavior. The next two stages are the determination and the action stages. And these are the stages where we really start moving forward with patients into getting some things done. The determination stage is when the patient says they agree with you and they're ready to make a change, but they haven't made the change yet. This is your planning for change stage with a patient. And this is really where the patient is agreeing that you have made some good points and they want to take some small steps towards improving their life. They might have, or they might ask for a plan. The providers to do at this point is to help them get some strategies for action, which we'll talk about when we set SMART goals, and also create your intervention. So come up with supports, a plan, and problem solve where the patient might have difficulties. Your action stage is when we actually are engaged in the change behavior. So once the behavior change is started, that's our action stage. That's when we're making the change, we're gaining experience. During this phase, you often see humility or gratitude because they're excited that they're making this behavior change in their lives. During this time, the provider's goal is to explore obstacles that are anticipated, and the intervention is to support self-efficacy, coping skills, cues, and rewards. So identifying where those pitfalls will be and rewarding behavior when they do things that they want to, that are alongside their long-term goals. And then the last two stages are maintenance and relapse. Maintenance stage is when that healthy habit has become the habit now. The behavior is the new normal. Now movement is a part of their everyday life. They're sustaining the change. They have wisdom. They continue to have that humility and gratitude. The provider to do in this stage is to identify and appreciate these new coping skills, and the intervention is to reinforce the use of the new skill for additional changes. Maybe in a different area. Maybe you started with movement and now they're ready to tackle diet, or now they're ready to tackle drinking, or now they're ready to tackle stress or sleep. So you start seeing how these behaviors, these healthy behaviors, can have a snowball effect for your patients. And then relapse is the last stage. And this happens to pretty much everyone at some point or another. This is where they had a previous behavior. Maybe it was a habit or maybe not, and it was abandoned for whatever reason. Oftentimes, this is when you'll have patients have shame, intense feelings, and your patients might drop off the face of the earth and not talk to you for a while. The providers to do is reach out and also help them learn from previous experience and move back into the action phase and reframe this experience of relapse from failure to a learning process. How can we prevent this from happening again? What things happened that were difficult that we could change for the next time? So these are your 6 steps for behavior change for any behavior. It's part of motivational interviewing. So how can we apply this more to exercise? So exercise counseling by doctors, I like to think about it as more 4 stages. So assess, assist, goal, and reassess. And we use these 4 stages when we are actually charting these exercise counseling visits in our medical charts. So assessment, you're going to assess the patient's stage of change, and that can be from the 6 layers of behavior change that we just talked about. Then you're going to assist the patient in mobilizing their motivation towards making that behavior change. And you're going to help them by doing that through setting a goal. This will be when we talk about setting SMART goals that are obtainable. These goals should align with the patient's core values and represent value-driven behavior, because it's more likely that they will succeed in that change long term. And then you're going to continually reassess the goals, reassess the plan, and make sure that you're maintaining motivation as a regular exerciser. Because once the motivation slips, then those habits tend to go away and we fall into relapse. So how do we help patients set these goals? I really like using SMART goals because it's something that a lot of people have heard about before. And these are specific, measurable, attainable, relevant, and timely goals. So what does this mean? So specific goals need to be detailed and clear. So they shouldn't be general. What am I doing? Why am I doing it? What will it require of me? And that can look like, if we're going to set something that's specific goal, it could be like, I want to exercise. I want to increase my exercise. Okay, that's fine, but that's not specific. I want to increase my exercise to 150 minutes a week. Okay, well, how much are you exercising right now? That's how we start narrowing down these specific goals. Measurable, there must be a point where you know that you've accomplished the goal. So like a time limit, a rep range, a goal weight, whatever it is, there has to be some way that you're going to actually measure your success. Attainable, it needs to be realistic. If someone's not moving at all, going straight from 0 steps to 10,000 steps is not a realistic goal. Relevant, it needs to be appropriate for what you're trying to accomplish with the patient, your overall goals, your overall health and wellness plan. What is that desired result? And timely, the goal needs to have an ending and a deadline for it to be successful. You need to make sure patients know that their end goal should have some time expiration date, or else it just continues forever and ever. And so this could look like something like this, SMART goals for the week. You could do them weekly and track it, or you could have more long-term goals. But I like this little SMART goal kind of handout or sheet that I can provide to patients so that they can track their goals themselves. So next we're going to move into exercise risk assessment. So exercise risk assessment, how do we make sure that exercise is safe for our patients or clients? So risk assessment for exercise, almost all patients will benefit from the right type of exercise. The right type is the key. The benefits almost always outweigh the risks of exercise and universal risk of sedentary lifestyle. So overall, exercise is going to be beneficial. But we do need to make sure that we are not just setting our patients up for failure by pushing them too hard, too fast. That will set someone up to get an injury. The risk of exercise-induced heart attack and sudden death most likely occurs in sedentary patients that are engaging in unaccustomed physical activity, so going from 0 to 100. Specifically, the risk of MI or sudden death in cardiac rehab is 1 in 2,200,000, or 1 in 117,000. So it is low, but it's still present. It's important to assess the change of injury or illness induced by exercise and make sure that you're not potentially worsening an injury, an overuse injury. And all of these things, all these risk assessment items can be obtained from just basic screening things that you'll do in a typical office visit. Obtaining a past medical history, a review of systems, identifying cardiac risk factors, and current activity level. So risk assessment for exercise, a good rule of thumb based on our Surgeon General. So previously inactive men over 40 and women over 50 and persons who are at high risk for cardiovascular disease should consult with a physician first prior to engaging in vigorous physical activity. But this does not include moderate intensity activity. And we're going to start most of the time with our patients at moderate or low intensity activity. So really, for the most part, unless if you're encouraging vigorous physical activity, which will define those parameters here in a minute, you're probably safe to encourage your patients to start moving some. So what are some pre-exercise prescription assessments? If you do have a patient in your office who says, hey, I want to start moving more, how do I do so? You need to collect some subjective and objective information. So subjective information, a history of the patient's current exercise regimen. You want to be able to understand the patient's health and exercise goals, their social history like tobacco, alcohol, and drugs, past medical history and any comorbidities associated. And I listed some there. And then objective information, you want to get their vital signs. They are vital for a reason. So height, weight, blood pressure, and oxygen level, also pulse. You want to do a heart, lung, neurologic and peripheral extremities exam, potentially. You might not do all those things, but assessing for what their heart's doing, what their lungs are doing, do they have any numbness or tingling or any issues that might make them a risk for a fall? And do they have good circulation to their extremities? If there's some concerns for osteoporosis, you can obtain a DEXA scan for monitoring processes. This is not needed in everyone. And if cardiovascular disease risk or there's a high metabolic concern, you could obtain some lab work like a lipid panel, a hemoglobin A1C for diabetes screening, an EKG, or a stress test. But those would be very specific patients who maybe have a history of disease or a high risk for cardiovascular disease. So what are some other assessments that you can do? So things that you would already have in your basic office visit with a patient are your vitals, your resting heart rate, and your blood pressure, as well as body composition, height, weight, BMI, and waist to hip ratio. The things that you could do depending on patient and doctor goals, and I'll go a little bit more into depth on these in the next few slides, is a cardiovascular assessment or an aerobic activity assessment. There's many different ways. There's a 1.5 mile jog test or 1 mile walk test, or the Queen's College Step Test, which we'll talk about here on the next slide. You also can assess muscular fitness, so strength. A single best is a 1 rep maximum bench press and leg press. Harder to do in office, but you could set up your office for this if you are maybe attached to a gym or see a lot of physical medicine or movement patients. And endurance fitness or endurance muscular fitness is our crunch and push-up test, which I'll describe. And then flexibility, the most common assessment for flexibility is a stretch and reach or a sit and reach. Overall, though, you need to obtain as much information as needed to appropriately categorize your patient into beginning, intermediate, or established exercise categories. And that might not be this whole list. You might be able to just do a basic history and physical exam and be able to recognize based on the history that this patient is in the intermediate risk category. But if you're really concerned or you really want to narrow things down, or the patient has some pretty specific fitness goals, you can do some of these assessments to get an idea of where you're starting. So the first aerobic activity assessment is the 1.5 mile test. This is not indicated, it's contraindicated in beginning exercisers. So people who have been sedentary. If someone has active symptoms of cardiovascular disease, significant risk factors for cardiovascular disease, or someone who cannot jog for at least 15 minutes continuously. The test itself is you run for 1.5 miles as fast as you can. The maximum time you can take is at 15 minutes, so a 10-minute mile. The purpose is to calculate the VO2 max, which can help you in identifying aerobic exercise goals, specifically how aggressively someone's going to exercise. And I put the calculation in here for you if you wanted to try it yourself and give you an example. The aerobic activity test I'll talk about next is the 1 mile test. This is a good option for beginners as you can jog or walk while doing this test. And the goal is to get heart rate over 120 beats per minute while walking in a person aged between 30 and 69 years old. After 1 mile, you're then going to measure heart rate for about 15 seconds, multiply by 4 to obtain your 1 minute recovery. Your calculation to get VO2 max here is much longer. It includes weight, age, time, and heart rate. And like many things in medicine, there is a gender component here, which you can choose to ignore if you'd like, but they do have a addition of 6.315 for people who identify as male, and they would not have that this factor here in someone who identifies as female. So that's something just to keep in mind for your patients you're working with. Then we also have the step test. This is another aerobic activity assessment. The step is about as high as a gymnasium bleacher, and the goal is the patient steps up and down for 3 minutes continuously. The average that they've calculated for men is 24 steps per minute with a heart rate around 96 beats per minute. And for women, it's 22 steps per minute with a heart rate around 88 beats per minute. After the completion of the 3 minutes, you take the pulse within the first 5 seconds of the recovery heart rate. So ideally between 5 to 20 seconds right after you're done with that test. And then you can see there's a calculation for VO2 max for male and for female. For strength assessments, I mentioned a few of them. The 1 rep maximum is by far the most standard. This is hard to perform in office, though. It's not vital for a patient who's first starting exercise, who doesn't know how to do these different techniques or lifts. As I mentioned, squat and bench tend to be the two that we do. Some people will do deadlift. It is easier to perform 3 to 5 reps at 60 to 80% of maximums. That is always an option. And then your last two are your endurance strength assessments, which is the push-up and the crunch. Push-up you can do on your knees or normal, and the goal is for push-ups until fatigue or inability to complete a push-up with a good form. Crunches, you have a beat that's 40 cadence, so using a metronome, and the goal is to get up to 75 reps or until the person can't keep up with that beat, until they're fatigued or unable to keep up with that 40 cadence beat. So those are your different assessments. Using whatever tools you need, those assessments, or just your history physical exam, or your patient's reported exercise history, you then can begin to kind of put your patient into these categories of low, moderate, or high risk. Low risk patients are safe to begin exercising without any further assessment. A moderate risk patient, you could begin with light to moderate intensity exercise, but they might need some further medical evaluation and testing prior to starting vigorous intensity exercise. That might be someone who's had previous heart disease before, maybe a heart attack, or some type of undiagnosed condition that you want to make sure that you're covering your bases and being safe prior to putting them into more of an intensive exercise regimen. And then high risk patients, these patients should undergo further medical testing before starting an exercise program that's anything above moderate risk. So they could start some light or low risk walking, but otherwise they should really probably be evaluated by a cardiovascular physician, a cardiologist, or potentially go through cardiac rehab. These would be your patients that are just getting out of the hospital after an event or after a significant surgery or procedure. So now we're going to get into the fun part, which is actually how to prescribe this exercise. What are some general guidelines? These are taken from several different locations, primarily the American College of Sports Medicine, as well as NASM, the National Academy of Sports Medicine. Those are two large certified personal trainer organizations that put out guidelines every year for how much Americans should exercise. So some general exercise recommendations. In a healthy adult who's less than 65 years of age, the goal is at least 150 to 300 minutes of moderate intensity aerobic physical activity per week, or 75 to 150 minutes of vigorous intensity aerobic physical activity per week, or a combination of the two. Essentially, if someone's exercising at a vigorous intensity level, it counts for 2 minutes of a moderate intensity level. And we'll define those two levels here in a moment. They also should do muscle strengthening activities of moderate or greater intensity that involve all your major muscle groups on at least 2 days per week, 150 minutes per week minimum. So that is kind of your general exercise goals for the majority of healthy adults. Now, there's some special populations we'll talk about, but first things first, I want to also, I want to bring in adults over the age of 65 and or adults with chronic illness who are aged 50 to 64. In these populations, you have the same recommendations, but we also include balance training as well as aerobic and strengthening activities to prevent falls. And if a person's unable to do the 150 minutes of moderate intensity aerobic activity per week, then do as much as their condition allows them to. Replacing sitting with light intensity activity. The more that you can get in with movement, the better. So there's a few different ways that we can measure intensity. So we've been talking about low intensity, moderate intensity, vigorous intensity. What do these things look like? So we have two different big categories, absolute intensity and relative intensity. Absolute intensity is the amount of energy that is expended during activity without considering a person's cardiorespiratory fitness or aerobic capacity. So this is not taking into the person's abilities into absolute intensity of exercise. We aren't taking into count how fit someone is when we're calculating absolute intensity. This is expressed in METs, metabolic equivalents of task units. So 1 MET is equivalent to your resting metabolic rate when you're lying flat, not doing anything, just your basic body functions. Moderate intensity is considered 3 to 5.9 METs. Okay. Relative intensity is the level of effort required to do an activity compared with a person's capacity. So relative intensity will be higher for a person with lower aerobic capacity than a person who is more fit. So here's some measurements of relative intensity. We have the rating of perceived exertion scale on the left, and we have the talk test on the right. I really like the talk test in my practice because I think it's super easy. So for light intensity activity, you can sing, you can carry on a conversation with no problem. Moderate intensity, you can speak in a full sentence, but cannot sing. Vigorous, you can only speak a few words at a time, and maximum, you can't speak at all. I think this is really easy for patients to recognize and to incorporate into their movement practices. So what are some examples of exercises that are certain intensities? So light intensity can be walking slowly at less than 2 miles per hour, doing light household chores, and you're able to speak in full sentences and can sing. Moderate would be walking briskly between 2.5 and 4 miles per hour, playing volleyball, raking the yard. You can speak in full sentences, but you're not able to sing your favorite song. And vigorous activities, jogging, running, carrying heavy groceries, strenuous fitness class, really a lot of the exercise or a lot of the things we associate with exercise are actually vigorous exercise. And this would be speaking in 2 to 3 word sentences. So now we're going to move into how we actually prescribe exercise to our patients in practice, because there are 2 different ways that we're going to talk about: the 5 A's model and the FIT: frequency, intensity, time, and type. So how do we actually prescribe exercises to patients? I like the 5 A's model, but there also is the FIT model: frequency, intensity, time, and type. So we'll go through both together. The 5 A's model to behavior change for exercise prescription is something that we use in medical practice, and it's often asked if you're ever audited in a chart note, they expect that you put it in your chart note. So it's important to understand it. It is assess, advise, agree, assist, and arrange. So assess. You assess the current fitness activity level, the type, the frequency, the intensity, and the duration. Any contraindications to physical activity, the patient's readiness for change, so those behavioral changes we talked about at the beginning, any patient-oriented benefits that are specific for that patient that either you identify or they identify, social supports for the patients, and self-efficacy, their confidence level that they can change their behavior. Your advising model, you're going to provide a structured, individually tailored counseling message based on the patient's stage of change. So if they're in the pre-contemplation change, you're going to say something to the effect of, as your doctor, it's my responsibility to recommend that you get at least 30 minutes of moderate intensity activity, like walking fast, at least 5 days per week. If they're in the contemplation stage, you might emphasize the benefits that the patient would care about now that you know some of their health and wellness goals. The preparation stage, you might suggest that the patient help someone that they care about get physically active for help, giving them that social support at the same time. Action and maintenance phase, be like, congratulations, super positive. You're doing one of those most important things you can do for your mental and your physical health. Personalize the risk to patients to make sure that they understand their specific risks to them, and personalize the immediate and long-term benefits of that change. Your agreement, you agree on the next steps together. So this is a patient practitioner, mutual agreement process. You aren't giving them the dogma that you expect them to follow. You then initiate that shared decision-making process like we do with most of our treatment plans based on the patient's stage of change. In pre-contemplation, you might ask them if you can talk about physical activity next time. For contemplation, you might discuss next steps for how we're going to actually make that change. Preparation, you're going to set up their plan. You're going to help them identify a start date when they're going to start moving. Make sure they have all the tools that they need to be successful. Action and maintenance, ask the patient if they're ready to start another healthy behavior or how you can help them maintain the current one. The assist portion is really where you get to do your doctoring, and we're going to talk about that here in a minute. Your assisting is where you're providing the patient with a written prescription of their exercise plan. You correct any misunderstandings, whether it's technique on a movement or just misunderstandings about benefits or what they should be doing, providing them information, resources. I give print materials, self-monitoring tools, internet-based resources, videos, etc. Get some social support going for the patient. Identify those barriers to change and offer some problem-solving techniques or tips. Teach the skills or recommend certain coping strategies. Describe options available and identify some community resources for them, and refer if appropriate. Things like cardiovascular rehab or patients who maybe have a very significant injury or comorbidities, you might be best to refer them to a physical therapist or a personal trainer. And you're going to arrange your follow-up appointment, providing phone and email reminders as that motivation factor and accountability factor, provide internet-based counseling potentially, or refer the patient for additional assistance. So some exercise prescription outlines for you. Exercise has kind of 4 components to it: a warm-up, conditioning, cool down, and flexibility. Your warm-up should be 5 to 10 minutes of low to moderate cardiopulmonary and muscular endurance activities. This could look like a walk or a slow jog. Your conditioning section is your main portion of your workout. That's anywhere from 20 to 60 minutes of either aerobic, resistance, neuromotor, or sport activities. And this portion of your workout can be obtained in 10-minute increments of time. You then do a cool down that will look similar to your warm-up, and ideally do some type of 10 minutes of flexibility or stretching exercises after a warm-up or a cool down period, either or. If you're doing it after a warm-up and prior to physical activity, you want to make that flexibility session more dynamic. If you're doing it after your cool down, it can be more static stretching. So some exercise categories. So you have 3 different categories. We're really going to talk about the beginner and the intermediate here. And just as a general guide, your patient is going to stay in the category of beginner for at least 2 to 3 months or until they feel comfortable moving into the intermediate category. And the patient may stay in the intermediate category for their life, unless if they're training for a specific goal or becoming an established athlete. Then they may move into the phase of becoming more of an elite athlete or a conditioned athlete after 3 to 4 months, depending on their goals and their level of intensity of training. But for our beginners, these are our people who are inactive or deconditioned. They might not have done any physical activity lately or ever. For aerobic training, you'll identify that maybe they've done no previous activities. You'll provide them with light to moderate activity to 20 to 30 minutes in 10-minute increments to get between 60 to 150 minutes per week. Start slow and steady. I think tracking walking is a really great way to get someone engaged who doesn't have a lot of previous activity or currently is more sedentary. Minimal previous activity, you're going to do light to moderate activity, but increase the minute goal, trying to get them up to that 150 minutes per week, which is the goal recommended to improve health and wellness. Strength training for either group of beginners was ideally 6 exercises, 1 to 2 sets of 8 to 12 reps, 2 to 3 times a week. And these 6 exercises should be focusing on our big areas of the body. So your hips and legs, your chest, your back, your shoulders, your lower back, and your abs or your core region. These major regions in the body are important to strengthen first prior to getting down to the minutia of these smaller areas of the body. So this might look like squats, modified push-ups, wall angels for back and shoulders. Low back might be reverse crunches, and abs may be pelvic tilt. So you can see you can get these exercises relatively easy working with your patients and creating things that work for them. For intermediate activity, these are people who are sporadically active. Maybe these are previous people who were in that elite or higher level of activity category and kind of work out intermittently now, or someone who, walks and does some activity, but it's not consistent or not that intense. Your aerobic training, you're going to want to, instead of light to moderate activity, you're going to want to push it just to moderate activity and try to hit that 150 minutes per week or more. For strength training, you're going to want to increase the exercises from 6 to 10, still keeping the same amount of sets, 2 sets of 8 to 12 reps, and then 2 to 3 times a week. But now we're going to separate things out. We're going to have hips and legs, quads, hamstrings, chest, back, shoulders, biceps, triceps, low back, and abs. So we're breaking down these larger body areas into more specific regions. You're going to increase those activities that you're doing with those patients. Another way to exercise prescribe is using the FIT exercise prescription guide to aerobic activity, and that is frequency, intensity, time, and type. Frequency is the number of days per week dedicated to an exercise session. Intensity is how hard someone's working out. Time is the length and the duration in minutes typically, and type is the mode of exercise performed. This can be a full activity or this can be one exercise. So some examples are, if someone's new to activity and low risk, you could have the frequency be 5 days per week at moderate intensity for 30 minutes and have them walk outside or on a treadmill. If someone's currently active and low risk, you could do 6 days a week, alternate moderate and vigorous activity, 30 minutes of alternate intensity every 5 minutes, and walking to running interval workout. So this is how you can apply the fit aerobic activity examples. So this is an example that I give to patients. It's my walking interval workout, where it's using 2-minute intervals to go slow and fast. And they can also increase this and do apply it to jogging or running. You can also apply the Fit Exercise Prescription Guide to resistance activity. So your frequency is the number of days per week dedicated to an exercise of each muscle group. You could train all muscle groups in the same day, or you could have special muscle groups on certain days of the week, like just upper body or just lower body. Your intensity, load, and weight is you're going to want to exercise to the point at which further reps would require assistance. You can test your 1-rep maximums, or you could use a rep number to maximums calculator. So there are calculators online that you could use. I tend to say start low and go slow. So don't push it to start with. Make sure you're starting at a weight that's doable. And sometimes a weight is just body weight or gravity or normal resistance. Time volume reps are performing the exercise once. Sets are a group of reps performed without stopping. And the greater the load, the fewer the reps you should do, and vice versa. So that's really when we talk more about power training versus endurance training. When we think about gaining bulk or tone, right? It depends on how heavy we're lifting and how many reps we're doing. And then type is the mode of exercise performed. So what does that look like? Well, first, just an aside on reps per load intensity. So a heavier load is more weight. We're really thinking more strength is the goal. So you're wanting to gain bulk, gain muscle, get stronger. You want to do less than 8 reps per set. Moderate load would be strength is balanced with endurance. So this is a good way. This is typically where I have patients train or clients. 8 to 15 reps per set is what you're looking at. And if this is your most common exercise prescription. A lighter load is less weight. This is more endurance as a goal. So going till fatigue, and more than 15 reps per set is typically done, but lighter load, less weight. So this is a typical strength training circuit I give to patients. I have the exercise, the amount of reps. They're supposed to do 2 to 3 sets each, and then the muscles that are targeted. So this is an example of really more of a lower body workout with a little bit of upper body core present. So what about certain special populations? We talked about people that have comorbidities and people over the age of 65, but there's some other special populations to consider. Exercise during pregnancy is highly recommended, at least 150 minutes of moderate intensity activity per week during pregnancy and during postpartum. Vigorous intensity aerobic activity can also be continued during pregnancy if the patient had that as a part of their normal routine prior to pregnancy. So if you got pregnant and you normally were a vigorous intensity worker outer, go for it. Keep doing the thing. Counsel your patient on, yes, continue to do the same amount of exercise that you're doing before, as long as you're able to tolerate. If someone was not a vigorous activity person prior to getting pregnant and then wants to jump into that vigorous activity once pregnancy is started, I would say slow and steady wins the race. Start at more of a moderate level of intensity and then work them up and see what they can do. Make sure that you're not pushing someone too hard, too fast. Light to moderate physical activity in pregnancy is completely fine. In our geriatric or older patients, low intensity physical activity is safe for asymptomatic sedentary adults, regardless if they've had a recent medical evaluation. So low intensity, slow walking, basic household chores, basic things you might do in your typical day, your typical ADLs, activities of daily living, completely fine. Make sure with these patients, you're including a little longer warm-up and cool-down period. Avoid vigorous intensity exercise unless if they already were exercising at that level. Low to moderate exercise is completely appropriate. Lower impact tends to be safer and more protective of joints, so be cautious if you're going to provide them with a bunch of calisthenics or jumping exercises, unless if that's something they've previously been doing. Make sure that there's a resistance, flexibility, and balance to decrease risk of falling. And also just make sure you're monitoring these patients because they do have an increased susceptibility to heat and cold. So close monitoring is important. These might be patients that best are you work out with them initially if they're first starting an exercise regimen under your watch. What about with exercise and smoking cessation? I know you've had a smoking cessation lecture this week or last week. just to keep in mind, a short bout of exercise can reduce someone's desire to smoke, decrease withdrawal symptoms, decrease anticipation of smoking being rewarding and pleasurable, and increase the latency period until the next cigarette. So overall, exercise should absolutely be worked into a smoking cessation program. One last thing before we go, I do want to put this down. You won't necessarily have any clue what this means now, but for the future, when you're in clinic and practicing medicine, there are ways to actually get paid for what you do besides providing cash-based services. So there are preventative counseling codes. So tuck the slide away and bring it back out when you're in the clinic or on your own in practice. CPT codes are codes that can be used for procedures. Preventative counseling codes are codes that can be used for any preventative health service in a normal office visit. So someone comes into your office for a cough and you also talk about movement or nutrition or preventative health, you can bill preventative counseling codes with the appropriate diagnosis code. This lists them there and the time that you need to spend counseling on whatever you're talking about. So for exercise, I can typically go for 15 to 30 minutes of counseling. So I can either bill a 99401 or 402. And these are all associated with their own reimbursement schedules based on the insurance that you bill with or contract with. For procedure codes, if you're actually doing exercise in office, like you're doing some physical therapy or rehab or personal training, 97110 is a code for therapeutic exercise in office for at least 8 minutes. To develop strength, range of motion, and flexibility. And this can be billed per area, so upper body, lower body. And then 97116 is for gait training. So this would be more aerobic activity like stair climbing or walking or monitoring someone's gait to prevent falls. That's all I have for you. I know that I'm not here physically in person to ask questions to me, but I do still have my NUNM email. So feel free to reach out to me there. You can also reach out to me directly through my website from my practice. There's an email online, contact@emmapetshow.com. Feel free to ask questions about anything I said here, and I'm happy to provide as much support as I can. Thanks for listening and happy exercise prescribing.